medication adherence is leveraging the e-fill team that we have. The e-fill team does refills based on standing orders. Now, as you all know, going to a pharmacy 12 times out of the year is kind of a pain. Like we forget, you know, and then you're like, oh, I've got a couple and you're 3 days late, and every month you're 3 days late. So what we did is we leveraged the e-fill team, and for the diabetic medications, the RAS antagonists and the statins, for those patients that have 30-day prescriptions that don't have any issues, that could move to a 90-day prescription, we allow them to automatically change them to a 90-day prescription. This tremendously helps adherence, because if it's sitting on your kitchen table for 90 full days, then you're more likely to take it every day during those 90 days. So this is the one last thing I want to talk to you about today, about some of the things that we're doing. We have really good partnerships with the payers out here in our community. We partner, one of our partnerships is with Blue Shields. And with Blue Shields, I'm working with them on the statin use in persons with diabetes, the SUP, and the statin therapy and prevention and treatment of cardiovascular disease, the SBC. These are both metrics that are actually clinical. It's not just whether a patient is taking their statin. It's actually, are they taking the right intensity of statin for what they need? So a physician or someone else, the box is checked that maybe they're adherent, but perhaps they're not in the right intensity to really have the best outcomes possible. So this is just a little cut and paste of an example of a weekly email I might get. Sometimes there's patients, and sometimes it's just we don't have any patients to escalate this week. But we take those and we dive deeper. We look into the chart. We kind of figure out why aren't they on the right intensity? Could they be? And then we partner with the physician and get them the results that they need if we can. So we're super excited. This is just a snapshot of some of the things we're doing. And thank you so much for your time. I'd like to welcome Dr. Balala.
So we're really excited about this model we have, and Mark talked about our care transformation efforts. So our next goal is we're trying to expand the patient-centered medical home to our specialty practices. So cardiology right now is in the midst of a lot of work so that we can get them recognized by NCQA as well as endocrinology. We really want to create a medical neighborhood where everybody is all taking care of that, because we know the best medical care can only account really for 20% of the outcomes. So focusing on social determinants of health is key. For those who are interested, there was a very good National Academy of Medicine perspective. The most popular perspective last year published by the NAM was on the use of an optimal team-based care to reduce clinician burnout. So that may be something that will pique your interest. It looks at the importance of creating a culture of psychological safety and team-based care. So thank you for allowing us to present our work. Thanks.
Thank you.
Thank you very much. That was certainly impressive, the efforts that you've had. It is now my privilege to bring back, by popular demand, Dr. Arevalo, who is going to talk about the Sutter Independent Program and their efforts in improving metrics and compliance.
I just want to acknowledge that Mercy Dignity hit well above the 90th percentile for our nation for statins and for controlling blood sugar. And Dr. Revlo's group, Sutter IPA, has hit the controlling blood pressure for diabetics and controlling blood sugar for diabetics. So none of the groups in the area are at 90th percentile across the board. Maybe that'll be next year. Thank you, Dr. Revlo, for being back.
Yeah, it was a pleasure. I mean, this is great to come back to literally home, because I think, as many of you know, Hattie and I and Parag Abutre, who was medical director at Mercy Medical Group at the time, along with the Right Care team, got together back in 2012 and helped create this forum. And so it's great that 8 years later, we're still active, coming together big idea was to share our best practices across, the region with the aim of reducing cardiovascular complications in the Sacramento region, and that we still have a lot of work to do. I mean, I think we've come a long ways, and I'm really excited that there continues to be a lot of support and a lot of interest. I want to thank Hattie and Liz and the rest of the team that really put this together with us, and that we continue to work to aim to reduce these complications. Sutter Independent Physicians is happy to participate. Just briefly, SIP is independent practices across the Sacramento region. We're only in 3 counties. We're in Placer, Sacramento, and Yolo County. There are 550 physicians and another 150 clinicians in the form of what we call advanced care clinicians, PAs and nurse practitioners. So we are a small group, and we have a very small administrative team that has been working diligently. We're very fortunate to be working very closely with Sutter Health because we partner in the managed care arena with Sutter Medical Group, and together we form something called the Sutter Physician Alliance, or a SPA. And so we're able to use some of the resources that Sutter Health has put together across the whole system to really address some of the key issues, because again, we are very small. The average practice has about 200 to 400 SIP patients, and so that's a challenge for us because those are the managed care patients, and it is a challenge that we are small in each of the individual practices. So we work real hard to try to get the attention of the physician and the clinicians as we try to improve the performance for our patients. So as I think Hattie mentioned, what I was asked to do is to talk about, well, how do you achieve some of these results? And particularly, there's 2 results. One of the first ones I wanted to talk to you about really was the blood pressure for cardiovascular, the non-diabetic individuals who have been diagnosed with high blood pressure. And as you can see, Sutter Independent Physicians is the third from the right. We, on 2018, which is the latest reports that IHA has put out there, we were not yet to hitting the 70 percentile, but the reason I bring this up, if you look at your tables, back in 2014, when we really first started working, and one of the drivers for me was because we were 40 percentile in this, and it was really embarrassing and very difficult to go out and talk to Sutter and talk to the community about the very important challenge that we had in being one of the lowest in the whole region. So we've come up fairly dramatically, and again, as she mentions, we've done pretty well around controlling high blood pressure in diabetics, individuals with diabetes. And in fact, we are now at 87 percentile, getting close to that 90 percentile. And I'm very proud of that because, again, the challenges, I'll talk a little bit about, as we are a small, part of the practice, is how do we get them to focus? Because we really are not just interested in the SIP patients. The whole focus is all your patients and saying, because we know clinicians and the practices, they just don't look at and say, well, this is a SIP patient, this is a Hill patient, this is a PPO patient, this is a straight Medicare patient. Really, it's improving the care for all our patients, and so I think that's been one of the positive things as we talk about things like controlling blood pressure in the people who have diabetes. In addition, we have also done a fairly decent job of controlling blood sugar in patients who have diabetes. As you can see, again, we're third from the right, and we sort of have topped the region. We're 72% as of the 2018 data. And I think, again, I'll talk a little bit about, well, so how do we do this? Because that's what Hattie asked me to do. And I think one of the things, again, I have to come back to right care, because back in around 2014, we actually were one of the first organizations locally to work with AMGA on Measure Our Pressure Down. And as all of you know, that they transitioned that out, but we helped promulgate it, and we used right care as the primary tool. And even within Sutter, it took me, I had to go through right care to get right care to support this, to get the attention of our SPA. And as you can see, the point out is that there are 8 planks in right care. And within SIP, when we looked at this, we said, well, we can't take every plank on, but let's focus on 4 planks. And so measure our pressure down at that time, back in 2014, 2015, we chose to focus on direct care staff training in accurate blood pressure measurements. And by the way, that's a challenging piece of work. Even to this day, we still have a lot of work to do to reach out to how do you do an appropriate blood pressure measurement. Because as you know, the measurement is the last blood pressure taken in that calendar year. And you can have somebody who's well controlled, and if you don't know how to take it, or you only take it once, and I'll give you an example. I went to see to get my colonoscopy done, and I went to see my GI, and I unfortunately was rushing like I usually do, and had I do UM, and so I had this very important case of trying to get somebody from Sutter to UCSF, and right in the midst as I got to my appointment, I got there in time, which is very surprising because I'm always late. And as I sat down, the first thing that the young lady did, she put a little wrist cuff and took my blood pressure, and you know, I was still kind of, you know, trying to catch my breath, and she said, oh, she says, your blood pressure is really high. And I said, oh, really? What is it? And she said, it's 150 or something, I can't remember. And then I said, you know what, can you do me a favor? I don't have high blood pressure, but can you come back in a little while, and I'll put my phone away, and I'll relax here, and then could you take it again? And could you get a blood pressure cuff? And she said, well, I'll see if I can find one. And so she came back with a blood pressure cuff, and I said, you know, actually, it wasn't 5 minutes, I remember about 25 minutes later, I get my blood pressure taken again, and this time it was right. I've never had high blood pressure, thank goodness, although I deserve it, but my blood pressure has always been very good, and so it was right back to the 128 over 72, whatever. And so to me, it was a dramatic example of the not to do, and if I would not have said to her, you know, hey, could you retake this, and which is really the protocol, then I would have been labeled, you know, inappropriately as a hypertensive individual. Although, you know, the things that I do, I'm surprised I'm not. So doing this and training and working with the staff, especially our primary care staff, which really was where we focused, we went a long way to, I think, addressing, you know, one of the challenges around accurate blood pressure taking and measurements. And then, of course, one of the most important things, and I'll mention that, is you know, creating a guide that you can help the clinicians. And so again, Right Care was my saving grace. And in 2014, we put together, and I'll show you in a second, the first iteration of the card that we stole from Geisinger, and we had at the time Geisinger Chief Medical Officer present. And I said, that's a great idea. Why don't we do it in Sacramento? And with the help of Hattie and I think Parag was also in this, we created the first version of this, which now you have a revised version because things change. And that's the beauty of having, you know, good clinical guidelines, is that, you know, you need to update them as we become smarter and more data supports the fact that, you know, we need to be up to date. And so, you know, having the guideline and using it and monitoring it, and that's one of the things that we did within our Measure Our Pressure Down program. And then the last thing, which to me was really one of the most really significant findings, is that we began to provide feedback to our specialists. Now, we didn't provide feedback on measuring or the level of the blood pressure. All we provided was, for all our patients, can you please take their blood pressure and just let us know that they've been moved by a claim that the blood pressure was taken. And just that intervention, I think, really helped us to improve our control of blood pressure in our hypertensive individuals. So again, I'll just talk a little bit more about you know, some of the other changes very briefly. We did now take the data and specifically share it with our clinicians, which every group has done, but we actually proactively started sharing data, especially to the docs who have EPIC, and I'll talk a little bit about that, because we started focusing on looking at their schedule, because we can see their schedule through the EPIC model, and in our particular IPA, Epic has been deployed to all the foundation model docs, but for us, we have to, one practice at a time, have to offer them Epic, and we created an incentive for them to use Epic because that allowed us to actually use the data and proactively identify, for example, in this case, who are your patients who are coming in today who need a measurement or need an IHA metric that is missing, and we could remind them of it. So again, this was only the docs who had, and especially only the PCPs, but that was a really important intervention that we created. And then we integrated some, not all of the quality metrics that are in IHA, but some of the IHA metrics, including the blood pressure, including blood pressure in diabetics. The other one that we included was colorectal cancer screening. Early on, we also had hemoglobin A1C measurements, measuring the hemoglobin A1C as part of the incentive program. And we saw our numbers increase dramatically when we not only provided an incentive, but providing them data on a frequent basis to help support improving their incentive performance. So here's the card that we helped create back in 2014. And it was promulgated not only locally here, but I think CAPG at the time was very interested in promulgating it across the state. And so we gave it to all our PCPs and worked with them to educate them about how the updated parameters were extremely important for them to notice and begin to work on. And of course, that's the other side. We then used, as I mentioned, this tool where we reached out to each of our PCP offices. Not everyone participated, but we had a large number that allowed us to come in and do specific training on accurate blood pressure readings, and this is the foldout that we used. One of the biggest interventions biggest cooperation that we created was telephonic disease management. I had hoped that Kim Buss, who is the was a medical director for telephonic disease management for many years, could be here to help me present, because I think, to me, this was one of the more powerful interventions that we did. Telephonic disease management in Sutter started locally here in what we used to call the Shisha region, the Sacramento region, and a focus on a couple of disease entities, and one of them was diabetes, the other one was CHF, and the third one was asthma that we helped create. Back in 2018, this was taken over by Sutter Health, and now is running enterprise-wide. But and I won't spend too much time, because I think you heard from what Mercy Medical Group is doing in terms of disease management, and exactly we do similar things, reaching out to the patients, identifying through a registry who are the patients that really have a need to reach out and support, and also reach out to the primary care doc, and engaging the patients both by education as well as reminding them about the fact that you don't seem to have a hemoglobin A1C test, or that last time you were coming in your blood pressure looked elevated. Can we help you identify if there are any challenges you might have, which include pharmacology and medication reconciliation. So our program, which is only telephonic, is still a really excellent program that now, as I mentioned, Sutter Health has put together as part of the population health program. That this year is a brand new revision of our care coordination program. And again, integral part of the program, and Dr. Kim Buss will now be running part of the care coordination program, and still will help purview over telephonic disease management in Sutter. Again, a really important piece of the work that we're doing with population health, that you see telephonic disease management in terms of identifying not only the individuals who currently have the disease, but the rising risk population. As I mentioned, there are the keys to our program around diabetes, around CHF and asthma, but we recently added hypertension management. Actually, not recently, that was 2016. and then hyperlipidemia as well as part of the disease management program. And these are the outcomes that they're measuring, and of course, our big focus in SIP is those 4 arrows that you see, at least was at that time. We've actually now added many more focused measures as part of our work with telephonic disease management. Again, as I mentioned, in 2016, we also helped facilitate, because we were using the disease, or the hypertensive cards that we put together in RightCare, and then in 2014, around the same time, Sutter, as I mentioned, Kim Buss was heading this, put together a guideline for Sutter. Took us a couple of years, but then in 2016, we agreed as an organization to use the Sutter Health Guidelines, and we transitioned to implementing those across our network, as well as the new lipid guidelines that should put together at the same time. And so I think, again, continuing our focus around new guidelines, yearly guidelines, that's been revised since, but in 2018 we were focused on the 2014 version of the Sutter Health hypertensive guidelines. As I mentioned, the clinical integration program is still a continual challenge for us, because we have roughly half of our clinicians, our practices are on the Sutter Health Epic program, where we can share the record, we can share the data, we can share information around the practice management part, which is scheduling and registration. But it's still a challenge. We started out when we couldn't get Epic, because I went to Epic and I tried to get a contract with them, but they told us we were too small. So in 2011, in 2007 is when we began a program that I called IMR, which is an integrated medical record, which was using G-centricity, which was one of the few integrated clinical records at the time that we could share the record. So by 2011, we had 76 physicians on it, a small number compared to the 500 that we had at the time. But at that time, Sutter Health finally agreed actually Epic finally agreed to provide a version of Epic that could be shared through the foundation model and the hospital model. It's the same record, and we transitioned from the IMR to Epic, and Epic, something called Epic Community Connect. And as of now, or by 2018, SIP had transitioned about 225 physicians, or about 42% to at that time to Epic, and it allowed us to now share the clinical record, identify patients more proactively, and it's still a huge challenge for the other 50% of the practices, because we're not able to do the same thing that we can do having an integrated record. But it's the same thing we share with most of IPAs across the country. And it's really a data capture problem, and having an integrated record, to the extent that you can get it deployed across your whole system, is really one of the best ways to improve care. We continue to offer incentives to try to get the remaining doctors within SIP to consider transitioning to the Sutter Epic. About 2 years ago, Hill, who also is one of the large IPAs in Sacramento, actually transitioned from their next-gen product to an Epic product. And although that's very helpful in something called Care Everywhere, where we can actually see the record now of not all, but most of the Hill patients and the SIP patients could be, they're all within our our Epic program, but there is care that gets provided, and that we're able to at least help transition some of the data in through Care Everywhere for the clinicians to support their non-SIP population. So we're really excited about that, using Care Everywhere to be able to improve care across the global population span. In terms of one of the challenges that we had around the non-Epic environment was getting the data about controlling the blood pressure. And so we used something called CPT2 codes, and we continue to offer incentives so that we can get the data using the CPT codes that can allow us to understand control of blood pressure. But it's still a challenge, and at this time we're trying to figure out more sort of improved ways. And through the help of RightCare, we started working on HIE in Sacramento, what we call the capital HIE. And unfortunately, we had to give up that work because of the cost involved in trying to create and sustain a functioning HIE. And hopefully, this is something that we can bring back for consideration and discussion, because it would really improve care across not just the SIP and the Sutter patients, but patients across the whole spectrum of our community. Also, those patients that are within the community clinics, community pharmacy, being able to share that data. That was our vision at the time. So haven't necessarily given up on it, but it's just a matter of trying to find when the right time is to bring back that question. So moving forward in 2020, just tell you a couple of good things. Besides this huge population health initiative that Sutter is moving forward with, we have decided to do our own quality team, and we do what we call our quality outreach and support team, which we used to do with Sutter under something called IQS, and now we've created our own team, and we have now 4 outreach specialists, a quality support person, and then our manager, who is Adam Chandler, and we believe that this will be helping us dramatically, because this team is partnering with each of the SIP PCP practices. They're going out to the practices. They're engaging not just the physicians but the staff themselves, providing data and being there in the offices. And we want to create this more focused partnership to really address not just some of the clinical quality things, but some of the utilization management challenges that we have. And we're now coordinating even more directly with this particular team and the telephonic disease management program. So with that, happy to answer any questions when question time comes up. Thank you for...
Thank you very much. Again, exciting progress that you've made, and I was happy to see that you're no longer too small. That's an impressive change that Epic made with that. Are we ready on the slides? So we're going to talk just quickly. I'll take the chairman's prerogative and rush through the next talk because we're behind in time, because I do want to save time for Jessica's presentation. We're going to talk briefly about UC Davis program. We looked at a program of getting to zero with equations. I think Hattie has been the pusher for this for years. And this briefly just shows on the top from inner heart and other things. Increase your fruits and vegetables and activity. Treat your high blood pressure, obesity, diabetes, smoking, stress, and cholesterol. And we can actually calculate the equation to get you to significantly zero risk at that time. That's the risk with inner heart. Here's the calculation, the actual logarithmic calculation I put out here from the pooled cohort study. Eric CHS, Cardia, and Framingham data for that. And it's a logarithmic, so I apologize for that, but I did actually calculate the log value that could get you to zero risk at that point in time for that. Here's the effort at UC Davis. You can see we took blood pressure in non-diabetics and diabetics, which was low at the time, and actually from 2016, 17, and 18 actually increased the compliance or the control in our non-diabetic population as well as in our diabetic population. We improved through 2018, and the question is, how did we do that? I didn't do that. Everybody did that. And here are 3 quick ways to look at for that. Again, you heard earlier the Measure Up, Pressure Down program. It is important to measure blood pressure the correct way. All of the NIH trials that we've conducted at UC Davis, We spend a lot of time at the national summaries organizing how to train people to measure blood pressure. You have to have them sit 5 minutes, resting, arm appropriate, in a non-stimulating room, often a boring area, and sometimes